Okay, so going back to imaging, and I'm going to make a strong statement here. Let's see if it holds after this talk. That every patient with cardiomyopathy should have an MRI. Maybe I'll modify it a little bit toward the end, but I have strong feeling about MRI in cardiomyopathy, and this is mainly because MRI can tackle the different areas that are needed in the assessment and management of patients with cardiomyopathy. That's namely looking at the etiology, looking at the recovery of function, and prognosis of patients with cardiomyopathy. So I think that we have the ability by cardiac MRI to gather all this information in a single test, and this is mainly because cardiomyopathy is a mixed bag. It's not a single disease, it's multiple etiologies. And when you see this mixed bag, putting them in the magnet, and they come out all separated. So you can see that this tool is very nice, not only to differentiate ischemic from non-ischemic, which is as good as it can be, like I showed before in the nuclear cardiology. But in nuclear cardiology, we are very much unable really to make the distinction between the different types of non-ischemic cardiomyopathy. And this is an area which is very well documented and studied over time for patients for MRI. This can be done using a very simple tool. You really don't need very sophisticated hardware, even if you have in your practice a magnet that has been around for 15 years. As long as you have what we call the basic cardiac sequences, or this is the term we use in MRI, so, or like think of sequences as the programs. So if you have a computer that has Microsoft Office and has simple Word and simple PowerPoint, you can just give it this talk. All that I need is a simple magnet that has cine function, myocardial perfusion, and scar and viability imaging. And if I have these tools, then I'm going to be able to make this distinction. So you really don't need to buy a very high-end, expensive machine to do that. I'm going to focus today on one sequence or just one program, although there are many, many in development. But this program is called delayed enhancement. Some of you think like you have heard the word, but let me just take you a little bit deep in this. This is considered the major breakthrough in cardiac MRI. And this came in the late 90s when researchers in Johns Hopkins and Northwestern University in Chicago, they were able to show that this sequence is going to be a very important tool in looking at scarring and tissue characterization. So normally when we give gadolinium to these patients, gadolinium is an extracellular agent. So it comes in the vessel, stays in there for a few seconds, and then wash out. However, if you have a scar, irrespective of the cause of the scar, this scar could be from infarct, from other diseases, then the gadolinium will hang out a little bit longer. What do we mean by a little bit longer? 10 minutes, 15 minutes, maximum 20 minutes. So it gives you an extra window of opportunity to image the gadolinium that's sitting in there for a longer time. So when we image it, how does it look? It's this white scar that appears in here. So I spoke before about nuclear cardiology, but I can tell you that MRI is much, much more sensitive to detect myocardial delayed enhancement. This is the same mouse model where they did induce a scar, and then they looked at the nuclear imaging and then look at histology. You can see that no matter how small the scar is, we can still see it by MRI. Nothing is seen by nuclear cardiology. And you can see here that by histology, it's even following the small dentations that we see in here. Now, how do we make the distinction between ischemic and non-ischemic cardiomyopathy? It's really the pattern of delayed enhancement. This is the seminal paper that was published by Raymond Kim when he was in Chicago, and it clearly shows areas that follow coronary territory, and it goes subendocardial from inside to outside. So ischemia hits the subendocardium first and goes to outside. So you can clearly see this is a patient who has an LAD scar. It's a large area where you don't see anything black. All what you see here is white. While if I look in here, This is the circ territory because it's the inferolateral wall. I see it only confined to the inner wall because I don't see it coming out on the outer wall. And here is a very small subendocardial inferior scar which is seen in multiple parameters. Now we use this information and gather further information by sometimes repeating the MRI, because if you image in the acute phase, you can potentially overestimate the amount of scar as you see in here. This is the same patient that were included in one of our research studies where we did MRI immediately after revascularization within 24 hours of primary PCI. Then we brought the patient 3 months later, and you can see the scar. So we tend to overestimate the amount of scar in the acute phase, and here it looks much less compared to what we see otherwise. But we also gather some extra information, like for example what we call here no reflow phenomena, where there is significant fibrin deposit that goes in the capillaries and block the arteries, block these capillaries. So even gadolinium is not getting in there. And this is called no reflow phenomena. Our colleagues in the cath lab know it very well. But now we provide them with a tool to see it and see how much is the no reflow. And it also has been associated from multiple studies with worse outcome. When we look at the viability, we can look at the amount of scar and how much you see in there, and we look at the chances of recovery. If you see no scar or 25% of the wall is scarred, the chance of recovery is very good. This drop down significantly if the scar thickness is 25 to 50%, and then below 50%, the chance of recovery is almost nil. So what we learned from this study here is that really, if you have a scar which is less than 50%, there is some hope. The hope goes up as the scar amount goes down. But if the scar thickness is more than 50%, really the hope is very, very limited. We also can look at the response to CRT, for example. I know some of our EP folks in the audience. And when you look at this, you can see that if there is a scar in the inferolateral wall, which is the wall that they use to restore synchrony in the ventricle, then this is a patient where there is limited benefit from CRT. Viability data compared to, for example, to what we heard, the Stitch trial and all of that, the viability data with MRI is now looking much more promising. And as you see in here, this is the study with only 144 patients. And you can clearly see that if there is viability and there is normal volumes, these patients do much better than those who were non-revascularized. So the point here is that if you have viability by MRI, the data is accumulating to show significant prognostic value with MRI. But I think the real benefit, which somebody could say viability imaging, ischemic, non-ischemic, I can get with many other modalities. But I think the niche that MRI has, which no other imaging modality has as of today, is really the distinction between the different non-ischemic cardiomyopathies. And this is an area which makes me feel that every cardiomyopathy or every unexplained cardiomyopathy should have an MRI to look for, because that could impact on the outcome. And what we look in here is not really the presence or absence of delayed enhancement, but rather the pattern of delayed enhancement. So we see delayed enhancement either in the mid-wall, we see it at the RV insertion point, we see it in the inferolateral point, and all of these are pointing to different diseases as you see in here. Or for example, it could be in the epicardial wall, or diffuse subendocardial, or otherwise. So I'll show you clear life examples of that, but before that, I want to take a step forward. In non-ischemic cardiomyopathy or presumed non-ischemic cardiomyopathy, you can still see ischemic MRI, delayed enhancement patterns. This is a study that they brought 90 patients with left ventricular dysfunction and 15 controls. The 90 left ventricular dysfunction patients, all of them went for cath. And they found out that 70% of them had no disease on cath. So these are what we presume are non-ischemic cardiomyopathy patients. But then when we look at the pattern of delayed enhancement, 13% of them have delayed enhancement pattern, which is related to CAD, which tells you that are we really sometimes underestimating the amount of ischemic cardiomyopathy that's there by looking just at a simple luminogram assessment and versus looking for further tools like IVUS and other tools like for example, plaque and further assessment. So sometimes you see 50% lesion, but that 50% lesion may have been had plaque rupture at some point, which may have resulted in worse outcome in these patients. So I'll show you a few cases here that these are all from my real life practice, and this is imaging MRI, cardiomyopathy by MRI is the most common indication in our practice. In fact, we've done more than 1,000 cases so far, and these are some of the cases. But if you want to see all the 1,000 cases, you're more than welcome to make a visit to our site. This is, for example, a patient who I saw even when I was in the US, 33-year-old man. He's got no past medical history. He presented on a Friday night. I was ready to pack home. I was covering the ER, and they told me, it's like, go down. We have a 33-year-old with syncope. We went in there, and while I'm seeing him, he goes into non-sustained ventricular tachycardia. Long story short, we did multiple workup for this patient, but then he made it to MRI, which really made the diagnosis. And what you see in here, so they promised me it will work. Anyway, what you will see on this movie is that there is significant LV dysfunction and regional wall motion abnormality. Don't tell me they don't move. Okay, so when we move forward, we do edema imaging. And edema imaging is really, in this black blood sequence, shows us the white myocardium. And there's significant white myocardium in here. But when we do the delayed enhancement, this is the normal myocardium in black, and you see the extensive amount of delayed enhancement in here. This pattern that comes as if it is like on top of the LV and extending to the RV has been best described in patients with cardiac sarcoidosis. And this is a patient who has cardiac sarcoidosis, and the images look very different to what we get on PET scan imaging with significant inflammation by FDG. The nice thing is that if you treat these patients with steroid with aggressive therapy and you repeat it, then you can actually see that the inflammation and the scarring or the edema has significantly reduced. In fact, in this patient, I have follow-up images only by PET, and you can see in here that this is the amount of FDG uptake before therapy, and this is the amount of FDG uptake after therapy. So you can see here that it significantly went down, and you can potentially get somewhat similar images with MRI if you choose to. But the reason we got this back because he ended up with a pacemaker, as you see in here, and the ICD after therapy, so we could not repeat the MRI in this patient. But you can see also, this is another patient, 56-year-old lady. She's admitted with shortness of breath, lower extremity swelling. She's got history of hypertension and diabetes. But compared to the other images, you can see how bright is the myocardium itself. It is much brighter than what we are used to see, and this is even before giving the gadolinium. So the left atrium is dilated, there's significant mitral regurgitation, but there's also some right ventricular dysfunction too. But when we do the delayed enhancement, the technologist called me, is like, doctor, I just cannot see the myocardium. I come down and this is what she was getting. I said, I know it's a diagnosis. Just by the fact that the technologist called me and said, I cannot null the myocardium or I cannot get black images, tells me that there's only one diagnosis in MRI that can give you that, and that's cardiac amyloidosis. This is yet another patient who had something very similar. You can see this diffuse uptake of gadolinium, and this is cardiac amyloidosis also. This patient even does not have significant hypertrophy yet, and he is actually a multiple myeloma patient who has apparently had myeloma heart, which is very similar to cardiac amyloidosis. And this is the pattern that we see with cardiac MRI. It has been correlated with stain actually from biopsies. And this pattern has a very high sensitivity, 80% specificity, 94%. Those of us who work with amyloidosis can tell you there is no other imaging modality that have this much of diagnostic accuracy data compared to what we get from otherwise. Our group just published a paper just in the past month where we describe even another more specific pattern for cardiac amyloidosis in MRI, which is left atrial enhancement, which is not seen in other cardiomyopathies. And this is the figure from that paper, where you can see that in cardiac amyloidosis, about 80% of the patients will have left atrial enhancement. But this was not seen in hypertensive heart disease and was not seen with dilated cardiomyopathy. So it has a very great distinctive pattern compared to other cardiomyopathies. But if we move on, I'll show you now just like a quick and show and tell some images. And here, for example, a 53-year-old lady presented with chest pain. She had anterolateral ST elevation MI. The ST elevation, they called the cath lab, and the cath lab said non-obstructive coronary disease. How often do you see that in the cath lab? It's pretty often. And there are different etiologies for that, and this is a patient who got only a peak troponin of 2.3, and this is her MRI. You can see this apical segmental wall motion abnormality in the anterior and apical ballooning. But when I do delayed enhancement, there is really just no delayed enhancement. So this is a case typical of Takotsubo. But can I call it Takotsubo just based on this? It is very hard because we have also similar cases, very similar. And then when you do delayed enhancement, you see a lot of edema and delayed enhancement on the anterior wall. And why is that? Because sometimes you could get plaque rupture in the proximal LAD. You take the patient to the cath lab, but you already started aspirin and heparin in the emergency room. By the time that the patient gets to the cath lab, he already auto-reperfused. They see nothing in the cath lab. So in my opinion, every single patient that has positive troponin and normal coronaries or no evidence of a obstructive lesion on cath should undergo a cardiac MRI. And there have been studies that have done that. And for example, this is one series where they found that 50% of patients were myocarditis, but myocardial infarction pattern was 11.6%. If you take another series, you can see that myocarditis was 60%, Takotsubo was about 14%, and myocardial infarction was 16%. So in other words, I caution people about jumping to the diagnosis of stress-induced cardiomyopathy or Takotsubo without getting an MRI, because things could go either way. And if you want to wait and look for the recovery of function, that's one option. But if you want your answer right now, rather than waiting for a significant amount of time to decide if the patient is going home on aspirin, Plavix, and other cardiac protective medication, then I think that you should get an MRI prior to discharge in these patients. This is a patient with 55-year-old lady, shortness of breath, and family history of heart disease. I don't need to say a single word. I'm sure all of you got the significant hypertrabeculation and LV non-compaction. This is a graduate student that came so far 6 times to our emergency room. Every time he comes in, he has a troponin higher than before, and he has multiple angiograms and cardiac CTs demonstrating normal coronaries. But this guy is an unlucky guy because he has myocardial edema in here and multiple areas of myocarditis. So this guy has 6 episodes of recurrent myocarditis as of now. If you look at this, is another unfortunate lady that I saw in my practice, and she had history of lupus. She came in with advanced heart failure, and we managed to get an MRI, and you can see that everything looks white. This lady had diffuse edema and diffuse delayed enhancement. She was on and off having VT storms, and she eventually died 1 week after this MRI from lupus carditis. So this is another lady who's got new onset heart failure. She has one family history of another family member who's got heart failure. You can clearly see this nice mid-wall delayed enhancement, which has been implicated in dilated cardiomyopathy, most likely secondary to non-ischemic cardiomyopathy. And the recent paper just published showing that this pattern alone predicts worse outcome among non-ischemic cardiomyopathy. So any patient with non-ischemic cardiomyopathy, if they have delayed enhancement, they will do worse than their counterparts with non-ischemic cardiomyopathy who have similar etiologies. This is hypertrophic cardiomyopathy with significant delayed enhancement or at the RV insertion point, and you can see the diffuse scarring that you see with hypertrophic cardiomyopathy. Not every hypertrophic cardiomyopathy patient will have delayed enhancement, but some will do. And this is an ARVD case with significant aneurysms. And I have just one slide left, which is looking that obviously we cannot just say every patient with cardiac MRI should undergo not every patient with cardiomyopathy should undergo cardiac MRI because there are still some limitations for cardiac MRI. There are a lot of patients with medical devices. Cardiac arrhythmias sometimes might limit our image quality, although we have some tools to deal with it. And sometimes the patient, if they are really too sick, they cannot tolerate cardiac MRI, although we are working hard to simplify our exam and make it very much shorter. And also chronic renal insufficiency has been associated with nephrogenic systemic fibrosis and may limit the use of gadolinium in this patient. So should everyone get an MRI? If they have no contraindication, yes, they should go for an MRI to look for etiology, recovery of function, and prognosis. Thank you very much.